My name is Portia Hall, and I'm a patient advocate for the DC GAPS Project for Pediatric Sickle Cell Patients here at Howard University. I would like to introduce our next speaker, Ms. Myrtle Williams. Is married. She has 4 daughters, 1 son, 4 granddaughters, and 2 grandsons. She is a Christian. Her education includes certified nursing, geriatric nursing assistant, association degree in medical assistant, degree in cosmetology, certificate in child care training, bachelor's of arts degree in early childhood education. She taught preschool class for 7 years and worked for 13 years as the director of faith-based child care center. Ms. Williams has retired 4 years ago when she underwent a complete hip replacement. Please welcome Ms. Myrtle Williams.
Good evening, everyone. My name is Myrtle Williams, and first of all, I'd like to thank you all for affording me the opportunity to participate in this 2015 symposium. The subject this year is one that I've become very familiar with for many years. Actually, I think that this particular subject believes that it's my best friend based on its frequency of visits. I'm here today to inform you that this subject is neither my friend nor anyone else's. I've tried my best to free myself of this thing called pain. I'm not a singer, like the choir that was here. I'm not a researcher. I'm not a doctor. But I can share my journey with pain with you today. I'm 64 years old, and I was diagnosed with fibromyalgia approximately 30 years ago. I was also diagnosed with osteoarthritis. I experienced severe pain, and it was chronic, from my neck to my toes, hands and fingers included. Also, I experienced migraine headaches as well. I didn't know what was wrong with me. I thought I had some type of bone or muscle cancer. I went to several doctors. They gave me pain medications, narcotics, but I was afraid to take so many pills. Actually, one of the doctors, he got so frustrated with me, he says, "Myrtle, why don't we just take you out in the back and shoot you?" And I said, well, let's do it. You know, I was just at the end. Finally, I went to a doctor, and I call him my guardian angel. He decided to test me for different disorders, ordered full body x-rays, body scans, and MRI scannings. That's when I first started treatment for arthritis and for the fibromyalgia. In the past, I have been prescribed muscle relaxers, pain management, and physical therapy. The pain meds caused me to have hiatal hernia and gastroesophageal, I knew I was going to have a problem pronouncing that word, reflux. I was then tested for Barrett's disease. Thank God it was negative, and I didn't have bone or muscle cancer either. The pain was so intense. I didn't know if my problem was coming from my back, knees, hips. I just didn't know. I had a few herniated discs, chronic low back pain, and bilateral hip pain. My knees were very painful as well. I was just a complete mess. Finally, tests proved that my hip sockets were bone on bone, no cushion. Finally, I was diagnosed with severe arthritis of both hips, with the right being the worst. After about a year of this excruciating pain and a few injections, I did decide to have a total right hip replacement. I had the least invasive surgery by one of the greatest surgeons in the world. That's my belief. I know doctors are here, and you guys are great too. He dislocated the hip, and he made a 2-inch incision on the front of my hip, and he performed the surgery. I started physical therapy the same day while my leg was actually still asleep. I remained in the hospital for 2 days. And after that, I was released, and I went home to a week of home therapy. After that, I went to physical therapy and I was introduced to aqua exercises. I love that, and I continue with the fitness program to this day. I walk 3 miles a day, weather permitting. I stopped taking those painkillers. I found that really warm baths, the aqua fitness, regular body massages, eating healthy, maintaining normal body weight, getting a good night's sleep, and prayer works very well for me. I am not pain-free, but I pamper my body and really take very good care of the temple God has given me. And that is my testimony here today regarding pain.
Good afternoon, everyone. My name is Dr. Javed Khan. I'm in the Department of Pediatrics, working as a research coordinator. Our next speaker is one of our own, Dr. Darbari, Dr. Darbari. She is a board-certified pediatric hematologist at the Children National Medical Center. Dr. Darbari started her work as a K-12 clinical research scholar studying genomics of the pain and the sickle cell disease here at Howard with Dr. Rana as her mentor. We are very proud that she has continued her work at NIH and CNMC, specializing in pain, especially the chronic pain, and has become an eminent scholar, researcher. And she is currently studying pain sensitization using the functional magnetic resonance imaging in individuals with a sickle cell disease. Welcome home, Dr. Darbari. Please welcome her.
Thank you very much, Javed. It's a great pleasure to come here and talk about sickle cell disease because good things did happen to me at Howard. This is where I got interested in sickle cell disease. I learned from Dr. Castro, Dr. Rana, Dr. Kark, and so many other people here. And it's so good to see so many of my teachers, including Dr. Casella and JJ here. So I'm very happy to come back, and it's really like coming home for me. So thank you so much for the invitation. So I don't have any conflict of interest, and I want to talk about a little bit. I don't have to tell what are the problems associated with pain in sickle cell disease, but in next 10 or 15 minutes I will try to cover these areas. That pain in sickle cell disease remains one of the major problems. And as we heard from Dr. Wilkie earlier, there are multiple mechanisms that can contribute to pain in sickle cell disease. And then I want to present a part of my research showing some of the evidence that how altered pain processing may be contributing to pain in sickle cell disease, and where do we go from here. So as we know, there are many, many complications of sickle cell disease, but pain remains one of the major problems. And pain in sickle cell disease, it's unique, I believe, because we really cannot compare all other pains to sickle cell pain, because there are really not many conditions where pain start as early as like 6 months of age or earlier. And we believe there are multiple mechanisms, but one of the underlying mechanisms which doesn't exist in other diseases like vaso-occlusion. So we know there are sickle cell, they block the blood vessel, cause vaso-occlusion, and pain start very early in life. And pain, Dr. Rana had kind of touched on this, that pain, it impacts many, many aspects of our life. It causes poor quality of life for patients and their caregivers. It has significant financial burden, and it was touched earlier, not only as a direct cost, like the money that we spend to take care of pain in sickle cell disease, but also indirect cost. So kids are missing school because of this. Parents they're not able to go to work, and so on. And also we know that individuals with sickle cell disease who have more pain, they have shorter lifespan. So they have earlier mortality compared to individuals with sickle cell disease who don't have that much pain. And pain in sickle cell disease is complex. Not two patients with sickle cell disease, even with the same genotype, they are same. So here you can see this is the data from the cooperative study that looked at a large population of sickle cell individuals and looked at, so here you can see that percent of group who had pain, and here are different genotypes, so like sickle cell anemia, SS, SC. And here I want to point out, even in SS, you can see there was significant variability. So like here, about 40% of patients really did not have any admission, but on the other extreme, there were people who had more than 6 hospitalization for pain in a year. And what we have realized now that admission for pain in sickle cell disease just represent the tip of the iceberg. There's a large population of individuals with sickle cell disease who experience daily pain. And this is the work from Dr. Smith, which showed that, daily pain is really, really common in this population. So about more than 50% of the patients had pain more than 50% of the days, and then there were 1/3 of the individuals who experienced pain more than 95% of the days. So they were in pain pretty much every day. So from here, I'm going to talk more about frequent persistent pain, and it's also listed on the handout you were given earlier today. So it's a problem, not only for patients because they are experiencing pain, but also for physicians because we are not able to control that pain. It's generally chronic in nature, and as Diana showed many times, it's subjective. We don't have an obvious source for pain beside the sickle cell disease. It generally doesn't respond to standard therapy, and if you have treated or have experienced with pain with sickle cell disease, we are still using a lot of opioids, which may or may not help the individuals. And then other interesting thing is that, some people are more prone to have this complication. So, and some of these patterns start to appear early. So sometimes we have adolescent, they are showing some high risk for hospitalization. Sometimes we see even in younger kids, and recently there was a paper published by Dr. Dampier showing that even younger kids, less than 5 years of age, there are certain individuals who are at high risk for having more pain. So then we wanted to look at the certain mechanism, primarily central mechanism, to see can we see some of the patterns which these individuals who are at high risk for pain may have. So a little bit about functional MRI. It's like MRI, but as name suggests, it's functional. So it looks at the different areas of the brain, how they are connected to each other. And it relies on the BOLT, or the blood oxygen level dependent signal changes. So it relies on the principle that the hemoglobin, when it's oxygenated, it has different magnetic characteristic, and when it's deoxygenated, it's different. So we are trying to figure out what are the difference. And two of the terms I want to bring it up here is, which I'll show, is the correlation and anti-correlation. So there are certain areas which get activated together, they are correlated to each other, two areas which goes in like opposite direction, they are anti-correlated to each other. The advantage of fMRI methodology is it's non-invasive, there's no radiation involved, and to some extent it gives us objective measure. And then we looked at the resting state connectivity. So patient was not really involved in a task, so which is ideal for a situation because, as you heard earlier, a lot of these patients have spontaneous pain and they may not have acute vaso-occlusion, but they continue to experience pain. And two of as you can imagine, there are like multiple networks in the brain, but these two networks have been shown to be important in the pain experience. The first one is the salience network, and it's the representation of whenever we feel pain. So if a local trauma happens, these are some of the areas which would be activated. Then the second one is called default mode network. So the first one was salience network, second one is default mode network, and this network is involved in the self-referential thinking. So whatever is important for the person, so that when we are not doing anything but kind of resting quietly and with closed eye, certain areas would be activated. And when the person gets engaged in a task or tries to do something else, this becomes deactivated. So this study was conducted at Children's Hospital, and we looked at the adolescent and young adults with sickle cell disease. And the goal of the study was to see if there are any differences in the connectivity pattern, kind of building on the work that Dr. Wilkie has done. Are there patterns, those are different, between the patients who have more hospitalization and more pain versus patients who have less hospitalization for pain. And we defined the pain phenotype. We looked at the number of hospitalization in past 1 year, and typically, in sickle cell population, individuals who have 3 or more hospitalization per year, we generally call them having severe disease. So this was our high pain phenotype. And individuals who had 2 or less hospitalization for pain, we call them low pain phenotype. All the patients underwent the resting state functional MRI. So patients were just asked to lay down in the scanner and not be involved in any task. None of the patients were in acute pain. So then they were not having any acute vaso-occlusive pain crisis. None of the patients had any leg ulcer or avascular necrosis of hip. So this is kind of general population, and you can see they were pretty comparable. But what I want to point out here is pretty much equal number of patients were on hydroxyurea, and this audience does not need too much introduction to hydroxyurea. This is one of the medication which is very, very effective in reducing acute pain associated with sickle cell disease. But here if you see, the hemoglobin F level were very different. So high pain group had a lower fetal hemoglobin compared to the low pain group. And here you can see that because these were the selection criteria, so patients who were in the high pain group, they had significantly higher number of visits to the emergency department for pain and also hospitalization for pain. So 2 types of analysis were done, and here's the one which was called seed-based region of interest, and I'll just highlight these. So here you can see, here is the high pain group and here is the low pain group. And remember I was telling you, so it believes on the principle there are certain areas of brain which are associated with the pain experience, and we call them pro-nociceptive areas. And there are certain areas of the brain which are anti-nociceptive, and these are the areas certain, like if you meditate or do things like that, or cognitive behavioral therapy to reduce pain, these are the areas which get activated. So anti-nociceptive areas and the pro-nociceptive area. So interestingly, an insula is considered one of the hubs of pain processing. So it's believed this area is very, very important in the processing of pain. So interestingly, what we found, like the high pain group had significant association with the pro-nociceptive area. So here, high pain group had greater connectivity to the pro-nociceptive structure like insula, and which are shown up here. On the other hand, the low pain group people had greater connectivity to the natural anti-nociceptive area, and which is shown here. So here you can see the high pain group had the negative connectivity to the anti-nociceptive area, while the low pain group had a positive connectivity to the anti-nociceptive area. So clearly there were a few differences which we found in our population. Then we also looked at the resting state scan to the salience and the other network that I had shown you earlier. And here also we saw there were significant differences between the low pain group and high pain group. So here, as you can see, that higher pain group, and this is the area which is the anti-nociceptive area. So here, high pain group was more negatively correlated. So they were going in opposite direction. The other interesting thing, as I had shown you earlier, that fetal hemoglobin was significantly different. So we don't know exactly what was the reason. As you know, the response to a medication can vary because of many regions, some certain like genetics or something like that. But here what we saw that fetal hemoglobin had beneficial effect, which we know clinically that patients who are on on hydroxyurea and have good response to fetal hemoglobin, they experience less pain. So here, high fetal hemoglobin was associated, had less connectivity to the pro-nociceptive area. On the other hand, it also had the greater connectivity to the anti-nociceptive area. So this was very, very interesting. So, but it's difficult to, since it was a case control study and not really a prospective study, so it's kind of hard to say what came first. Are those the people who were going to experience high pain anyway, and that's why they had this connectivity pattern, or they were responding well to hydroxyurea, that's why they had this good connectivity pattern. So to summarize the finding, what we found that patients, sickle cell patients with low and high rates of pain showed difference in connectivity pattern by the resting state fMRI. And these findings, I mean, it was a small pilot study, a case control study, but it suggests this possible role of central mechanism, as Diana showed earlier. And then also, which we clinically knew, that high fetal hemoglobin has beneficial effect in terms of connectivity in brain pattern. So where do we go from here? As I said, it was a small study, so definitely we have to validate these findings in a larger study. And then this methodology can be used, hopefully it can be used again to study the mechanism which can contribute to pain in sickle cell disease. And again, as we heard earlier, the pain is a multimodal experience. They are not only the medication, but also, as we heard, that which are non-medication can also help relieve pain. So we need to test some of the pharmacologic as well as non-pharmacologic methods to control pain in sickle cell disease. And since it's a centrally acting mechanism, maybe there are certain drugs that we can use centrally, and hopefully that can help in the pain of sickle cell disease. But the most important thing is, I think, is doing these longitudinal studies. So we need to have a cohort of children which we start very young age and follow them to see what really contributes to pain and how can we improve the experience. With that, I will finish, and I would like to acknowledge people who participated in the study. So at Children's, my colleague, Dr. Vizina, Jordanis, and Nadia, and at NIH, Dr. James Taylor, and the analysis for the functional MRI was done by the Pain Institute at University of Michigan at Ann Arbor. Thank you very much. Yes.
Were these patients actually having pain at the time with the functional MRI? Or was that in between the pain?
Okay. So none of the patients were having acute pain, but as we heard, a lot of patients have chronic pain, so they were having their baseline pain. So some of the patients, there were a few who were on long-acting pain medication, and their baseline pain was like 3 or 4. So that was present, but many of them, they had, so whatever was their baseline pain level, they continued to have, but none of them were having acute pain, what we call. Yes?
I know you've also done work on quantitative sensory testing. Have you done any correlation between fMRI and quantitative sensory testing?
So not for this, sorry. Oh, okay. So the question is, so in a different population, I have done quantitative sensory testing in sickle cell disease, and if we have done functional MRI as well as quantitative sensory testing in the same group. No, we have not done that, and the QST was in a different population, and this was a different population, but that is exactly the future direction, because the advantage of that is QST is great, but also if we can see what do we see in the brain at the time when we do the QST would be very, very helpful. So that's the future direction. In some other diseases it has been done. Yes?
Can you explain or give us your idea of the mechanism of pain development in sickle cell disease?
That's $1 million question. So it's a mechanism, so it depends on what age. It's like, multimodal. So, and what we can tell from patient population, when the patients are young, they have different kind of pain. So when, like I showed you the picture, when they are very young, and it's primarily the vaso-occlusion. So we think it's maybe the primarily nociceptive when they are young. And we know that once they are adults, they have lot of chronic pain. And so something happens in about teenage years when you transition from the acute pain phenotype to more of like a chronic pain or the persistent pain phenotype. And as they get older, there are multiple, and Diana had shown a slide, very nice slide, like what are the different things that can contribute to pain. So clearly all these patients who have sickle cell disease, they have a reason for, sickle cell itself is a cause for pain, but then you can have the end organ damage, like avascular necrosis, you can have leg ulcer, that could contribute to pain, but then also the change in the pathway. So like, the chronic, once you have all these different connectivity pattern, any stimulus, you may feel that as a pain. So that can also contribute to pain. Then again, there are like genetic factor, there are like multiple factors, and each person is different. So, that's really a very, very important area to study. Yes?
Terrific data, fascinating work. As a clinician, were you surprised at the strength of the association with fetal hemoglobin? And is there clinical experience that the hydroxyurea responders show a fall in the level of pain?
So hydroxyurea is a very effective therapy. It increases the fetal hemoglobin in sickle cell individuals, and we know that it reduces, acute pain episodes. So that has been well known. But I was very impressed with the finding that between the, what we saw, the difference in the amount of fetal hemoglobin between the two groups, and so that's why longitudinal studies are very important. And I think with the baby hug cohort, it would be very, very interesting to see these individuals who started on hydroxyurea very early and as a result had less acute VOCs, what is their pain phenotype down the road? So if you look at the connectivity, maybe they have the beneficial connectivity patterns and they have less pain and maybe less chronic pain down the road. We don't know. I mean, maybe hopefully we'll have that data in a few years, but it would be very, very important information. Yes.
Yes, I actually worked with Dr. Roland when I was 19 years old, hospital 3 months, and typed a lot of his stuff to go to. That's the way I came away from home. So I'm very grateful to be in this space. My brother graduated from the school at about 23 in medicine, and he's hyperpurchase. He's a surgeon. I hear all of this. I'm more of an artist. And you talk about cognitive behavioral therapy, and I've been east, I guess you're from the east, and it's a lot of invasive medicine that I'm hearing about, but do we always go to the root cause, like what's happening? I know the child is already diagnosed with the sickle cell trait or the disease, yes, but are there other underlying factors that would exacerbate the illness? And have there been treatments, for example, the cognitive, meditation, aromatherapy, hydrotherapy, exercise, diet? It would be palliative probably, and not curative, but it could probably alleviate the illness. So I'm trying to see where we stand in your research, and what is research in here with regards to using like acupressure, acupuncture, meditation, along with the medication.
Yes.
And I'm really
Right. So that's a very, very good point. And so that's why I wanted to show not only pharmacologic treatment, but non-pharmacologic treatments are very, very important in controlling pain. And there's a clearly, on functional MRI, the advantage of that is it gives us objective measures, so we can see a lot of things which otherwise, I mean, it's one, along with the patient report, I think it kind of gives you objective as well as subjective criteria to assess a treatment. And in fibromyalgia, there was a study that was presented last year where meditation clearly showed the beneficial effect. So there was certain area with acute pain, and it was very impressive to see the certain area of the part of the brain that was activated with pain and with meditation, and they did an excellent job in this study showing that how it impacted and how it lowered the area of pain. It was not done in sickle cell, so I don't have information. And about the acupuncture, in the recent meeting on sickle cell, they showed the mice model of sickle cell, and they showed how it affected the pain perception in the mice. So they used the acupuncture, they blocked the pain, and it seemed very effective. And there's like some studies that have been published in acupuncture in sickle cell, and it seemed to have some benefits.
Also acupressure.
Yeah, I have not seen a study. I have seen a study on acupuncture, but not on acupressure.
Thank you very much, Dr. Darbari.